friends, Wockhardt is working on the ethos of the life wins, and we all are here together to serve this purpose. Before we start our program, I'd like to say something about my company. We are the across the globe for the pharma. We are leading beta blockers brand in the US, UK, Denmark, Nigeria, and also part of the India, Bangladesh, and Pakistan. Being a Wockhardt hospitals, we are in the 8th place in the India and 3rd place in the Mumbai. Dear friends, I like to start something and say something before we begin. If we practice something in life, your mind has to think. And if we think something, then we have to apply our mind for that particular task. And if we apply our mind, our knowledge will gain. And if our knowledge will gain, our skill will improve. And if our skill will improve, it makes us great. And it gives the success in life. This is not my word, but this is the word of APJ Abdul Kalam, who is called as the missile man in the India. So let's join hands together for this wonderful session. And I like to thank for your participations, people, those who are coming from the outside of the Mumbai, some are people coming from the Punas, and also from our other hospitals locations. Thank you very much.
To me by Dr. Gunadhar Padhi, who is our full-time consultant intensivist at Sterling Wockhardt Hospital, Vashi. He was previously working with Sion Hospital in emergency and trauma care. He has given many such lectures and presentations in national level seminars.
Working on airway anatomy. See, airway anatomy is very important because unless until we don't know what we are dealing with, it is very difficult for us to handle the situation. That is why it is I have kept this talk as a first talk. Everybody should be thorough about the airway anatomy. And in my talk, what I am going to talk is anatomy of the airway and what is the difference between an adult and pediatric airway. Airway anatomy imaging, where I will be showing you some of the X-ray pictures of the airways and the difficult airways, and the airway sonoanatomy. Means nowadays the ultrasound has advanced so much that now the AHA, the American Heart Association, the ACLS, everybody they have stressed on the emphasis on ultrasound on the intubations actually. Now when we are students, that time there is a very little role of ultrasound, but nowadays everybody says you should always do the things with ultrasound actually. Whether you are doing a intubation, whether you are doing a percute tracheostomy, whether you are doing a what is called as a pneumonia patient, you are dealing with a pneumonia patient, always the ultrasound is the primary importance. That's why nowadays the chest ultrasound, airway ultrasound, your cardiac ultrasounds, abdominal ultrasound, they are coming into in a big way. So this is just a basic. I will teach about the basic about the airway sonoanatomy. Okay. So first thing is, so basically when you deal with the airway, our airway is divided into two types. One is called the upper airway, and the second one is called the lower airway. So why this division is important? Because the upper airway you can see from by our view actually, by laryngoscope, by fiber optic bronchoscope, but the lower airway, like from what is trachea, bronchi, bronchioles, actually we can't see in our open eyes. That is why those things, if there is any difficulty, suppose there is a growth in the trachea, there is a growth in the bronchus or in the alveoli, in those cases you require some special investigations like CT scan, X-rays, ultrasound, or any other advanced modalities like fiber optic bronchoscope. That is why the lower airway is also very important. But what we see actually the upper airway, and the upper airway starts from your mouth, nasopharynx, oropharynx, pharynx, and the larynx. So these are the parts of the upper airway. So if you see, this is the upper airway. It starts from the mouth. Mouth cavity is most important because when you try to intubate one patient, we will put a laryngoscope into the patient's mouth. That's why any growth, any foreign body, any tumor in the mouth, they can make your intubation difficult. Okay, that is important. And the most important part of the mouth is the tongue actually. So whenever the patient is become unconscious or unresponsiveness, the tongue muscles, they lose their tone. Okay, because of this decrease in the tone of the tongue muscles, the tongue can go backwards and it can cause the airway obstruction. That is why whenever the patient become unconscious, your first primary important is to maintain the muscles of the tongue actually, the proper tone of the tongue muscles. How you maintain the tone of the tongue muscles? By doing the triple maneuver. So what is triple maneuver? Head tilt, chin lift and jaw thrust. So this is the basic maneuver everybody should be familiarized with. Now we are bringing with the mannequins also. You should practice what is triple maneuver. I want each and every staff, every sister and every person who is working in the ICU to train in this triple maneuver. Head tilt, chin lift and jaw thrust. And if the patient is having a cervical spine injury, okay, suppose the patient is having a cervical spine injury, in that case you don't have to give head tilt and chin lift, okay, only jaw thrust is recommended. So any patients with trauma, if he comes to you and you suspect that the patient is having a cervical spine injury, in those cases only jaw thrust is recommended. So how do you give the jaw thrust? That you are going to practice in the practical session, okay. Now next comes your pharyngeal mucosa and the pharyngeal muscles, okay. So the pharyngeal mucosa and the pharyngeal muscles, there is tonsils are there. So if any patient is having a problem in the tonsils, like tonsillitis, or there is any adenoid hypertrophy like here, so those cases your airway might be very much difficult, okay. So you should be careful. Any patient who comes to sore throat, comes with recurrent sore throat, recurrent URTI, and you want to intubate that patient, you should be extra careful. Those patients can go into spasm also, okay. And next will be your what is called the upper part of the larynx, okay. Upper part of the larynx, which is consist of your epiglottis, your vallecula and the two vocal cords, okay. So patients who are having chronic laryngitis, immediately if you want to put an endotracheal tube, they can go into the spasm. So that is the importance of the upper airway. But if you come to the lower airway comprises of your trachea, then bronchus, bronchioles, okay. So once you pass the endotracheal tube through the vocal cords, now the tube will go to the trachea. So what is the importance of the trachea? So most of the times if you cannot intubate, if you cannot put the tube through the mouth, so what you do, the surgeons can practice tracheostomy, or as an anesthetist or intensivist we can practice cricothyroidotomy, so which can be done from outside. So in that case everybody should know the anatomy from the outside, what is the cricothyroid membrane and what is your cricotracheal membranes, okay. That is important for your cricothyroidotomy, which is an emergency procedure. If you cannot ventilate a patient, cannot intubate a patient, the next step is going for putting an LMA, and if your LMA fails or your combi tube fails, next step will be emergency cricothyroidotomy. Once you do an emergency cricothyroidotomy, then you have to ventilate the patient with tracheal jet ventilation, okay. So this is your upper airway and the lower airway. So if you go to the internal anatomy, so if you see the trachea and the larynx, they consist of lot of cartilages. Biggest cartilage is your thyroid cartilage, okay. Then comes your hyoid bone and your tracheal cartilages and a cricoid cartilage. These three cartilages are very, very important. Why thyroid cartilage is important? Because whenever you are going to do a tracheostomy or cricothyroidotomy, you have to palpate the thyroid cartilage. That is something called as laryngeal handshake, okay. You have to hold the larynx on the left hand by the means of your two fingers to the thyroid cartilage, and slowly comes on your fingers to the cricothyroid membrane. That is why this for laryngeal handshake, everybody should know the thyroid cartilage. This thyroid cartilage is nothing but your external prominence, which is called the Adam's apple, okay. And next to the thyroid cartilage, the ligaments, which is the intrinsic ligaments. The intrinsic ligaments are your cricotracheal ligament, your cricothyroid membrane. This cricothyroid membrane, this is very, very important. This is the cricothyroid membrane where you have to do your emergency cricothyroidotomy, okay, cricothyroidotomy, because there you have to puncture your needle, go through the cricothyroid membrane, put your guide wire and put your different kind of gadgets which are available for cricothyroidotomy. That you will be dealing in your workstation, okay. Then next comes your cricoid cartilage. Cricoid cartilage is nothing but a ring separate cartilage. This is the cricoid cartilage, which is a ring separate cartilage. This cartilage is very important because this is the only cartilage in the trachea which is completely circular. Rest other cartilages in the trachea are semicircular, okay. So whenever you suspect that the patient is a full stomach, if the patient is going to aspirate and you are intubating, so what you do basically, this is called Selix maneuver. Selix maneuver. So in Selix maneuver, you give a pressure on the cricoid cartilage and you compress the esophagus, because cricoid cartilage is a ring separate cartilage, so you compress the esophagus behind your vertebral body. So that any patient who has a full stomach, the food cannot come through the esophagus and it can go into the stomach. So any patient who you suspect the patient is in full stomach, you should give a Selix maneuver to compress your cricoid cartilage. That is the importance of cricoid cartilage, okay. And below the cricoid cartilage, you can find number of tracheal cartilages or tracheal rings where you can go for tracheostomy. So tracheostomy is practiced below the cricoid cartilage, okay. There is something called as high tracheostomy. There is something called as a low tracheostomy. So okay, so usually low tracheostomies are not preferred in the ICU. What is preferred is the high tracheostomy. Okay, and sometimes we can practice bedside tracheostomy also, which is usually practiced by the registrars and the intensivists. That is called percutaneous tracheostomy. It is not surgical tracheostomy. Surgical tracheostomy, you take the patient to the OT, do a tracheostomy by the help of a surgeon. But percutaneous tracheostomy is minimally invasive. You don't have to do a cut actually. You have to just do a nick. Okay, with the nick, you have to retract your tracheal rings and put the endotracheal tube. So it is very less invasive. It is a bedside procedure. And today also they have brought the mannequin to make you practice this percutaneous tracheostomy. It's also one of the part of your airway management. Okay. Now everybody knows how the vocal cords looks. So this is the blade of the laryngoscope. You can see this beautifully. These two cords, these two structures actually. Okay. And these are the glottic openings. You can see here the tracheal rings are visible when you try to intubate. These are the two vocal cords. Okay, so this is the normal structures. But in our practice, lot of times we can face lot of abnormal things also. Okay, lot of abnormal things also. So somebody may find a growth in the vocal cord. Somebody may find a growth in the trachea also. In those cases, even if you see the vocal cord, your tube cannot go. Tube cannot go. So in those cases also your tracheostomy or picothyroidotomy is indicated. So it is not always mandatory that once you see the cord, you can pass the tube. Okay, so there are a lot of things beyond the cord also that you should be careful about. And this is the view of the vocal cord. You see this is a chink, small chink, and this is the biggest chink. This is when the patient is taking a, you can see the deep inspiration. The vocal cords are wide apart, and this is just when the patient is in the phase of expiration. The vocal cords are contracting, and these are the two beautifully arytenoid cartilage. Okay, and this is the arytenoid cartilage, and below this cord is the epiglottis. So your important landmark when you try to intubate the patient is the epiglottis. Okay, so you see the epiglottis, then don't include the epiglottis in your blade and then put the endotracheal tube. If you include the epiglottis in your blade, then you are not going to see the vocal cord. So you have to leave the epiglottis. You have to go below the epiglottis. Okay. Okay, so this is just a nice view of your what is called. Okay, this is called the vocal cord view. One person is doing a fiber optic through the one of the nose. When he passes the fiber optic through the nose, initially he can see the turbinate actually. Okay, this is the turbinate. This is the nasal turbinate. Now once he goes more and more into the turbinate, he can see the floor of the nasopharynx. Okay, so this is the floor of the nasopharynx. Now once he put more that fiber optic bronchoscope. See, fiber optic bronchoscope, the length is quite big, so you have to put it through the nose and see what is seen in the monitor. Okay, so this is the floor of the nasopharynx. Then now you have to flex the scope. Now this is the palate mucosa. Okay, so this is the palate, soft palate and hard palate. Now you have to go under the palate. Okay, so this is the epiglottis. Can you see the epiglottis? This is the epiglottis. Okay, so once you see the epiglottis, below the epiglottis, you can see that opening, beautiful opening with white glistening structure. This is the vocal cord. This is the vocal cord. So this is the two anterior commissure of the vocal cord, and behind this, these are the two arytenoid cartilage. Okay, so the arytenoid cartilage sometimes can block your view in the fiber optic laryngoscope, fiber optic bronchoscope. So you should be very, very careful. That's why you have to move, you have to flex the anterior part of your fiber optic bronchoscope. Okay. So at this point, downward flex the scope to visualize the tracheal lumen. Now he is going into inside the tracheal lumen. Okay. Now you will see your tracheal cartilages. So this is the tracheal cartilage. You can see the ring separate cartilage inside the trachea. And now he will thread the tube through the fiber optic bronchoscope, through the nose. Okay, so this is how you do a fiber optic bronchoscope actually. But before that, your preparation for fiber optic bronchoscope is very, very important, because if you don't prepare the patient well in the fiber optic bronchoscope, then you may going to lose the view, because sometimes the patient may cough, sometimes the patient may sneeze, sometimes the patient can undergo spasm. So for that, your local anesthesia is very, very important. So you have to give the local anesthesia, one in the trachea, okay, second in the both the side of your hyoid bone to block the superior laryngeal nerve. Okay, so I am going to come to that. What is the nerve supply of the larynx, so that you can easily know. So this is the nerve supply of the larynx. You can see this is the vocal cord, and the vocal cord is a watershed line. Okay, everything above the vocal cord is supplied by your superior laryngeal nerve. Okay, and everything below your vocal cord is supplied by your recurrent laryngeal nerve. Understand? That is why these two different divisions of the nerve supply is there. That is why first you have to block the superior laryngeal nerve by giving a local infiltration at the angle of the hyoid bone on the both the side with 2 cc of xylocaine. Okay, and to block this recurrent laryngeal nerve, you have to first extend your neck, palpate for the tracheal cartilages, and go between both the tracheal cartilages, 5 cc of lignocaine, aspirate little bit. Okay, then inject, so that the whole of your tracheal mucosa it got anesthetized. Understand? So this is how you block the local anesthesia, and after giving the local anesthesia, then you have to put your fiber optic bronchoscope to the patient's mouth, because you cannot put the bronchoscope when the patient is not anesthetized. The patient will cough, the patient will vomit, and you will going to lose all your views. Understand? Okay. Now this is basically the adult trachea, but what is more important is your pediatric airways. See here, basically lot of times you may face a child who comes to you with respiratory failure. A child comes to you with respiratory difficulty, breathing difficulty. You may have to intubate the patient. So remember that the child airway is more difficult than the adult airway. The child has a more difficult airway than the adult airway. Why? Because of these differences. So what are the differences? The difference is that you can see the child has a smaller nose. Okay, they are primarily the nose breathers. So if you block their mouth and block their nose, they can have respiratory difficulty. Okay, and their head size is quite larger as compared to their airway size actually. Not in case of adult. See, in case of adult, the airway is well developed. You can find the proper anatomy, and the head size is quite smaller as compared to your laryngeal mucosa and the laryngeal size. Whereas in case of pediatric patient, the head size is quite bigger, and your what is called as your cricoid cartilage is less well developed, and the patient can have easily airway obstruction, and the tongue size is very large in compared to the child this thing. Okay, and the more space is taken up by the tongue. That is why they are more prone for obstruction by the tongue in pediatric patient. That's why you should be very careful. And the pediatric patient also, they don't give you much time, because their oxygen reserve capacity is very low. So they can easily desaturate. Whereas the adult can maintain the saturation for up to 10 minutes, 15 minutes. The child cannot maintain the saturation for more than 3 minutes to 5 minutes. Understand? So that's why you should be very careful for a child's while you are intubating a child. You have to give enough oxygen, lot of oxygen, at least for 10 to 15 minutes or 20 minutes. Then you have to take care of all these things. Then airway structures are more easily obstructed in case of children. Understand? And as the child grows, become more and more small, like infant, like neonate, the airway difficulty will be more and more. That you have to keep in mind. So airway will be, your laryngeal will be more difficult in case of infant, in case of neonate, then in case of little bit of bigger child, then in case of adult. Understand? So you should be take care of this thing in your mind while you are intubating a pediatric patient. And if you see the laryngeal structure also, you can see in a pediatric patient, the larynx almost looks like a funnel shape. Whereas in adult, it is almost look like a cylindrical. So what happens if you can pass the tube through the upper part of the larynx, your tube can go and block here, because the narrowest part in case of children is your cricoid cartilage. Okay. But in case of adult, you can see once you pass the tube through the laryngeal inlet, the tube can easily go through the whole of the larynx. Understand? That is why in case of children you can find more difficulty, because even if you pass the tube can go and obstruct in the narrowest part, that is the cricoid cartilage, and make you difficulty. Okay? And also the cricothyroid ligaments, they are very soft, they can easily rupture, so you have to be very careful. The tube can perforate your ligaments, the tube can damage your structures. The mucosa is also very soft, so that you can damage the mucosa also during intubation. So the pediatric patient, they can have more trauma due to intubations than that of the adult patient. Whereas adult patient, they are less prone for trauma because the cartilages are well developed, the mucosa is little bit rigid, and the larynx is almost cylindrical inside. Okay, so this is just the normal anatomy. Remember, this is the normal anatomy. But in our practice, we may find lot of abnormal things. So always anticipate some abnormal anatomy or abnormal structures while you are intubating the patients. Okay, so what are the abnormal things you can visualize? Like say in these patients. Can you see this patient? The patient is having a large goiter. Large goiter. So in these patients, the visualization of the trachea and the vocal cords will be very, very tough because these can be compressed by your thyroid mass. Okay, and to locate your thyroid cartilage is also very difficult. So in this case, tracheostomy also may not be possible, or cricothyroidotomy may not be possible. So these patients are really creative trouble. Suppose if this patient desaturate in your ICU, or if this patient deteriorate, the only option you have with you is fiber optic bronchoscopy. Okay, because surgeons can find difficulty, or very, very low tracheostomy. You can take the patient to the operation theatre. Sometimes this patient need cardiopulmonary bypass to secure the airway. Because when you don't go from here, immediately you have to put the patient on cardiopulmonary bypass to secure the oxygenation. Understand? So these patients really give you very trouble in airway, and they can sometimes come to your ICU. These patients, where the growth is on the lateral side of your what is called as neck. Okay, so they can compress the airway little bit. Okay, so even if you able to see the vocal cord, your tube might not go because the larynx is already compromised because of the growth. So these are the two difficult patients or abnormal anatomy. You can see this patient. Can you see what is happening to this patient? What is there in the patient? CA tongue. Okay, there is a large growth in the mucosa of the tongue. So you cannot able to put your laryngoscope blade in this patient. So this patient, they straightway go for tracheostomy or cricothyroidotomy. Okay. So this patient sometimes comes to you with lot of problems. This patient, what is happening to this patient? You can see this is a CA buccal mucosa or CA cheek. Okay, where the mouth opening is almost restricted. There is no mouth opening at all. Mouth opening is almost restricted. Okay, so what is the option for this patient? Same, fiber optic. If your patient is going to be taken by the OT or in the emergencies, fiber optic. But if this patient comes to ICU in sudden desaturation, obviously you should immediately go for tracheostomy. You should call the surgeons, ENT surgeons, and go for tracheostomy. Okay, there is no point in trying for your blind intubations. Okay, because or LMA is also a good option. If the mouth opening is good or little bit okay, then LMA is also a good option. Okay. Similarly, all these patients, pediatric patients, they are having congenital anomalies. This may be syndromic child. You can see the lip is deviated to one side. One side there is a facial palsy. The eyelids are closed. These patients always anticipate difficulty in intubations. They can be difficulty in mask holding, or they can be difficulty in intubations. Both the things can happen simultaneously. Okay. Okay. So these patients, you see the nose, congenital anomalies, cleft palate, cleft lip. So they may have some internal problems, internal abnormal growth in abnormal structure in the larynx also. Okay, so this patient can have difficulty in mask holding and difficulty in intubation also. Okay, similarly this patient, these are the patients where you know the tongue, your cleft palate, the hard palate and soft palate is almost fused, the cervical vertebrae is almost fused. They can have restricted your neck movements, restricted mouth movement. So better to go for the fiber optic in this patient rather than trying for intubation. Or if in emergency they comes, you try intubation, but if the intubation is not possible, immediately go for tracheostomy. Okay. Similarly with this case also, you can see the patient is having a retrogranthia, the mandible is totally receded inside. Okay, so there is no space only. You cannot extend your neck in this patient. Okay. Now the next part or last part I will come to you about the airway anatomy imaging. So I will just go through what is the normal anatomy. Every patient you should take a X-ray chest after intubation, and if you see the X-ray chest, this is for your basic beginners. You can see the trachea is there, and the heart sit like this. This is the left border, right border, inferior border, okay, and the superior vena cava. This is just like this. Okay, so you can see the trachea is so high in the chest X-ray. And this is the lateral X-ray. On the lateral X-ray, you can see the heart shadow is here, and this is the mediastinum and the hilum, and above that is the trachea, okay, and behind is the vertebral body. Both the anterior epilateral X-rays and anterior posterior X-rays and the lateral X-rays, both are important actually in some patients. But the normal position of the endotracheal tube, you can see the endotracheal tube is here. The tip you can see almost 5 cm above the carina. This is very important. In ICU patient, it should be at least 5 cm above the carina, because sometimes the patient can flex their neck, extend their head. So it should not happen that during the flexion of the neck, the endotracheal tube can go inside the patient right bronchus and cause endobronchial intubation, and there is a collapse of the left side of the lung, like in this case. So this is the normal position. This is the endotracheal tube normal position, and you see this is the division of the trachea. Okay, so almost this distance should be maintained. So if you find the endotracheal tube is very close to carina, you should little bit withdraw the tube. Okay. So just we are talking about the endobronchial intubation. You see the endotracheal tube here is almost gone into the right bronchus, and because of that the whole of the left lung is get collapsed. So these are the common incidences happening in our ICU because of the improper monitoring. Okay. Similarly, in this case, you can see the trachea is almost compressed to the right. You can see the trachea lumen is very narrow, and the trachea is almost compressed to the right because of the large growth in the left side of the chest. So this is the abnormal anatomy you can always anticipate in case of mediastinal tumors or mediastinal growths. Here also you can see the trachea lumen is very narrow here. You can see the very narrow. So if you pass a tube also, beyond this there is a normal caliber, but here the trachea is almost narrow. So even if you try to intubate, your tube might not go here. So these patients will require a tracheostomy instead of endotracheal intubations. Okay, and in the lateral X-ray of the neck, this is the normal lateral X-ray of the neck. You can see this is the nasopharynx, this is the oropharynx, this is the hyoid bone, and this is the trachea. This is the most important part. This is the trachea, and you have to always remember the gap between your cervical spine and the trachea. The gap should be minimal. Okay, and this is the thyroid cartilage. In some patients, like here, you can see the gap is very much large, or more than 4 cm actually, between the vertebral body and the trachea. So this is because of the paravertebral abscess. If there is an abscess behind the trachea, paravertebral abscess, you can compress your trachea forward. Okay, so this is the case. So in those cases also, your intubation and airway might be very difficult. Okay. Similarly, patients with large tonsils, they can compress your airway, or large adenoid, they can also compress your airway. And always remember, if the patient is having a tonsils or adenoid, there you cannot put a nasal tube, because nasal tube can go and obstruct your tonsils or adenoid, and patient can have severe bleeding. The patient can die on table. Okay, so if the patient is having adenoid or severe hypertrophy of the tonsil, always try oral intubation. Never try go for the nasal intubations. Okay, this is the normal CT scan of the chest. You can see the esophagus and the trachea. Here is the trachea lumen, and here is the esophagus. Okay. Similarly, the CT chest also sometimes gives you a lot of guide. Okay, you can see the trachea is almost compressed, almost came to right side because of the large growth in the mediastinum. So these patients, they can have difficulty, or in fact those are the cases of difficult airway or difficult intubations. Okay, here also you can see because of the mass, the airway is almost moved to the right side of the chest. Okay, and last part will be the ultrasound of the neck. Okay, see, you people don't do the ultrasound, I understand. I also don't do, I rarely do, but this is now the trend in the near future. Now everybody after 5 years, you can see they only localize the intubations by ultrasound, or doing the endotracheal intubation by the ultrasound. Okay, so this is the one, this is the one video just I am going to show you. So how you go for the ultrasound of the neck. So first you put your probe here horizontally, and you can see the structures there. So first ring is your, what is called is your thyroid cartilage. Okay. As you move your ultrasound probe down and down, you can see here is your cricothyroid membrane. Here is the cricothyroid membrane. This is the point where you do the cricothyroid bubble. Okay. After that you will find some air bubbles or air fluid levels. Okay. As you go down, more and more down, you can see the cricoid cartilage. Okay. So clear? So cricoid cartilage, thyroid cartilage, cricothyroid membrane, and here's the point of puncture here of your cricothyroid bubble. So this is now the trend in the future, near future. Okay. And similarly, this is a video which shows that how you intubate with your ultrasound, or how you confirm the placement of your endotracheal tube with the ultrasound. So whenever you place the probe like this, the big structure where what you find is the trachea, and beside the trachea you can find the esophagus. Okay. So now the person is going to put the tube. The tube can go into esophagus or it can go into the trachea. Okay. Listen. Now see here, the first thing, the tube is going into the esophagus. So you will find some vibrations here in the esophageal mucosa. Okay. Or what is called as the double chin apparatus. Anyway, so whenever you find, normally the tube will go into the trachea, you will find some of the vibrations in the trachea. But once it go into the esophagus, you can find the esophagus, there is some vibration in the esophagus. Like that, you can find two shadows, one shadow here and one shadow here. If it is in the esophagus, the esophageal, you can find a lot of vibration in the esophagus. Okay. Now once you put the tube in the trachea, you can find some vibration in the trachea. So, and if the tube is in the esophagus, you can find the double chin appearance. Now, normally esophageal lumen, which is not visible in the ultrasound, it can become large and it will be visible. Okay. So this is how you confirm the placement of your endotracheal tube. And second method is the ETCO2. Everybody, every ICU or every ER should have a ETCO2 monitor in their ER, because that is now the standard of care. And the international guidelines suggest that once you put an endotracheal tube, you have to confirm it with either ETCO2 if it is or ultrasound. These are the two standards of care. Okay. So my take home message is always, the first thing is take a proper training, practice yourself, practice and practice. Then you become an expert in the airway management. Second message is also training, practice.
Request Dr. Akshay to take us further with his lecture on airway management guidelines in ICU patients.
Very few patients we will have that difficult airway or difficult intubation. I'll just talk about what is difficult airway, what is difficult intubation. But please remember few things basic when you go to the ICU. These are the prerequisites you should have, and even if you can't intubate, please remember you should be able to ventilate. There is a difference between ventilation and intubation. I'll just come to that point. And basically, OT and ICU are different. In the operation theatre, everything is protected. Everything you need to plan in advance. There is no dire emergency in the OT, until you are sleeping. So please remember, in the operation theatre, patient is awake. You can plan, replan. You can call the patient after some time. Or if you can relax in the operation theatre. But in ICU, you can't afford to relax. You never know which point of time the patient will come back, which point of time the air will get collapsed. So in the ICU, at most of the time you should be on the toes. Please remember, operation theatre, OT, intubation, ventilation is a little bit different. In the ICU, there is an emergency in case it arises. By and large, in the OT, you will not have this problem. And in OT, somebody will be there to help you, assist you. ICU, it won't be possible every time that somebody is there with you. Now, what are the factors which contribute for the difficult airway or difficult intubation? One is patient is hypoxic. The moment patient comes, respiratory rate around 30, you put a nasal mask, you put a venturi mask, you put a NRBM saturation going down. You again put 84, 85, 85. One point will come when you feel that the tube is necessary. Patient is hypoxic. That is a critical situation. Second, head injury and all that. You can't allow the head injury patient to keep on intubating. Head injury is very delicate patients. Please remember, head injury, myocardial injury, infarct, LVF. A little bit here and there, patient is poor. Most important, head injury. The moment you try to put the tube and you are not able to put the tube or the patient coughs, ICP will go haywire. So remember, if you ask me 2 or 3 patients where you should be very cautious to put an endotracheal tube is a head injury. The moment patient coughs, the thing are screwed. ICP will go haywire. Already stroke is there, suppose this is 10, it might go down to 9, 8, 7, 6. Head injury, please make sure what you do, patient is completely sedated. Use appropriate propofol, fentanyl. Propofol is slightly better because it decreases the ICP. But see that in the head injury patient, when you are trying to put the tube, patient should not cough at all. It's very clear. Or you have a very not very sure, not very confident, but you're pretty sure that you can see the cords, give succinyl choline or recruitment intubate the patient. But head injury should not cuff at all. What I mean to say, the moment he or she will cuff, raise ICP and things will be bad. Second stuff, you already know. Take a laryngoscope in a hand, there is suction machine is not working, the mama is not there. So you see that everything is available, everybody is available. Sometimes suction is not working, the bottle is filled. So see that every duty, every 8 hours, everything is taken care of. Cylinder, every time you need to check it. You attach everything and the cylinder is not working. The oxygen is finished. So see that these things should not happen. Or you take a patient to suppose CT scan or USG or somewhere outside, intubated patient. See that in between that oxygen cylinder is not getting empty. Suppose you plan to go to Vashi for suppose CT or MRI on the way, or in the ICU also, in the hospital also, from one place to another place. You see that the proper storage is there. It will take half an hour, 1 hour. This shouldn't happen that in between, then the oxygen cylinder is empty and the doctor doesn't know. Go to the back to the ICU or go to the CT scan. So you go to the center which is the nearest. Please remember that. But to avoid this, you see that there is no mishap. Oxygen cylinder is proper. Third, instruments we already spoke. Every time you check the battery actually. Most of the time you put the scope and battery is off. Then instead of blaming the sister, you see that before taking the laryngoscope in your hand, at least battery is working. Position and lack of space. Lack of space, by and large, Wockhardt does not have a problem because there is enough space in the ICU. Sometimes you want to move the patient. If you can't move, you need to move the patient. Ideally, you only need to move. You can't, by and large, head injury and all that, don't move the patient. Space is adequate. Positioning, we have lack of time. Comorbidities, patient is diabetic, hypertension, obesity, OSA and all that. Like advanced gadgets, every time you don't need very advanced gadgets. Basic you should, laryngoscope, LMA, combi tube. You can, by and large, you can either ventilate or oxygenate the patient. Basically, ICP, microlesion, patient has emitting and vomiting and trauma. So suppose the facial trauma, there is a lot of difficulty, and patient just now vomited. By and large, Indian people, they have by and large this tendency for the constipation, so vomiting and all that. Recently, the patient has taken some food or butt juice, they have a tendency for vomiting. So before you take a tube in your hand, before you take a laryngoscope in your hand, kindly go through this if the time permits. If the time permits, then everything is haywire. If the time does not permit you, patient is cardiac arrest, hypoxic, desaturating, you don't have anything, then that time you can't keep on thinking of this. But at the same point of time, when it is pre-planned, it's a semi-emergency, you need to consider all these issues. Now what next? Assessment, you need to assess if there is a time. In the ICU, you don't have time. So the time then you assess, you do the assessment, is anticipated easy airway, anticipated difficult airway. The moment you assess the patient, you know it's easy or difficult. If it is difficult, you can plan accordingly. Now the question is that you see the patient, you anticipate it's easy, and then it has become difficult. The two issues that you did not anticipate properly. Or there is something comes up which you need to face it now and maintain the oxygenation. So what you do in that place, I'll just tell you what is it. It's a difficult airway. Conventionally trained anesthesiologist, this is the definition. Experience difficult with mask ventilation or difficult with tracheal intubation or both. Those who is qualified, they had a problem either ventilating or either intubation or both. This is the difficult airway. Now, difficult intubation, normally trained anesthesiologist. This is not 3 minutes, this is 3 attempts basically. I'm sorry for that. You try to intubate the patient, take a laryngoscope, 3 times you attempt, you can't intubate, this is difficult. Problem is not with the person, please remember, see the definition. He is normally trained anesthesiologist. The airway is difficult. 3 times he attempted, he can't intubate. That you label as a difficult. And 10 minutes he is trying, not able to put the tube, is a difficult intubation. More than 3 attempts, more than 10 minutes. There are 2 entities basically, cannot ventilate and cannot intubate. These are 2 different entities. Cannot ventilate, cannot intubate. It's very clear, cannot intubate. You can't put tube. Cannot ventilate, I'll just talk to that point. Yeah, basically, even if you, at the end of day, at the end of all this, even if you don't understand anything, or even if you don't want to follow anything, please remember, there will not here. Please remember only one thing. You can afford to remember most of the things, but at least one thing you remember, that every patient every person who is a healthcare, basically what we are, should know how to do the back mask ventilation. There should be bag and there should be mask at the end, at the bed end of every ICU patient. Please remember. Now onwards what we'll see, at least there is one bag and one mask at every patient. It shouldn't happen that the bag is different, the mask is different, the tube is there. It should not be separate. You never know, middle of the night, 2 o'clock, 3 o'clock, somebody becomes bad. You can't keep on running tube to get the face mask, to get the bag. So every patient in the ICU, along with an oxygen connector, there should be bag, mask which is connected. Please remember that. There should be no leak in the mask or bag. By the time you attach everything, then you realize that there is a leak. So every time we should check it every 8 hours, 12 hours, what is the time period. See that in the ICU, at least in between the 2 beds, there is a one bag mask which is connected. You can't run away. Patient has a cardiac arrest. You can't do chest compression, same time get a mask, get connected. So bag mask is mandatory, and every person, anesthetic, I think all anesthetic knows how to do bag mask ventilation, but every person in the ICU who is working in the emergency setup, either on the floor, either on the OPD, or either in the casualty or in the ICU, they should know how to do bag mask ventilation. It's clear? There's a technique, see in the afternoon, I think they'll show you how to do, but even if you can't intubate, that is fine. 90% of the patient, everybody can intubate, 10% nobody can intubate, please remember that. And you don't require skill to intubate. You require a lot of skills, but at one point of time when you are very sure, for this, if you can't ventilate, patient will die, please remember. If you can't intubate patient, chance that he will die but less. But if you can't ventilate, he will definitely die. And this does not require too much of skill, this only requires practice. So from now onwards, you see that everybody can do bag mask ventilation. It is a C and E technique, it will teach you. But see that the bag mask is available, and any point of time, if you can't put the tube, at least you can do the bag mask ventilation and save the time till some senior person comes in. So checklist, just now I discussed, everybody should have the suction apparatus. Endotracheal tube, suppose you want to put a 7 number, now you should be ready with 8 number and 6 number. It's clear, one tube above and low. So what are the number you anticipate in the adult? Suppose you want 8 number, same time you should have 7 number also and 8.5 number also. Sedation, see that patient is properly sedated before intubation. It's traumatic experience. Putting the tube in somebody's mouth who is awake, it's very traumatic. So see that patient is properly sedated. And after sedation, the BP should not fall. So what you do, you give a lot of IV force, except there is a cardiac issue. Monitor, you should know what is happening. Saturation going down, 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 you don't know, you are keeping intubation, and suddenly the patient is bad. So suddenly nobody becomes bad, please remember. In the ICU, nobody becomes bad suddenly. You realize it suddenly. Unless and until there is a ventricular fibrillation, patient will give you time. He will not die suddenly. You did not BP drop, then patient output drop, then he become drowsy, then suddenly you see that ventricular fibrillation is but it doesn't happen. You realize it late. So please remember, there is enough time, you should have a monitor. Defibrillator at any point of time, you don't know which point of time arrhythmia, so defibrillator should be ready. Laryngoscope should be workable with adequate batteries. This is for more academics actually. The moment you see the patient, how will you know that whether I'll be able to put the tube or no? Just ask the patient to say ah. When you can see everything, hard palate, soft palate, uvula and pillars, easy. When the patient says ah, you can say only tongue, it's difficult. It's clear? Ask the patient to say ah, if he is in the position to say. Patient is drowsy and you ask him ah, he will not do that. Please remember, conscious. This is all guidelines are made for the patients who are in the operation theatre, going for OT or tomorrow or day after tomorrow. So, by and large, suppose you are fortunate, ask the patient to say ah, you can say soft palate, hard palate, uvula. Things are a little bit easy. You can't say anything. Things are difficult. At any point of time, you are in doubt. Consider and assume that everything is difficult. It's clear? So again, this is how do you predict difficult intubation? Basically, more than 3 attempts or more than 10 minutes by qualified anesthetic person. And there is there are multiple slows when you anticipate that there is a difficult intubation. Malampatti 3 or 4, just now we see. Patient has obstructive sleep apnea, cervical spine issue, mouth opening. Ask the patient to open the mouth, less than 3 centimeter. To give a point, it comes around 12 points. More than 3 is a tough time. Patient is comatose, severe hypoxia. And the person who is going to put the tube is not trained, then you give 1 score. More than 3 square, you anticipate the difficult intubation. Basically, more the score, more is the difficult. That is the only thing. So to come back to this point, if you see any of these, patient has obese, obstructive sleep apnea, mouth opening difficult, patient is comatose, severe hypoxia, then anticipate that there is a big problem. Now, coming back to difficult intubation, basically you just see the score. More than 3 there is a problem, less than 3 there might be a problem. More than 3 then at least 2% should be there. Please remember while putting the tube. Metal bed, mandatory rapid sequence intubation might require at any point of time. If you have this advanced gadget, visual laryngoscope or fiber optic laryngoscope, that is additional benefit to you, but it's not recommended. If you have, that is well and good. So again, basically, you put a laryngoscope, you can see everything, direct laryngoscope, put the tube, everything is fine, patient is okay. But then you can't see anything, you see there are a lot of secretions. If there is no secretions, you do a video laryngoscope and you put the tube. But a lot of secretions you need to aspirate. Instead of aspirate, you put a laryngoscope, you can't see anything, difficult intubation, then you need a video laryngoscope or LMA and fiber optic bronchoscope. I'll just talk for about LMA in next few slides. But remember, there are intubation bundles basically. Dr. Aklesh will talk about that. But remember, there's 7 P's in universal when you do the mechanical ventilation or intubation. There are 7 P's. Just remember P word. P basically presence of 2 operators. Whenever you anticipate difficult airway, see that 2 people are there who are qualified. Preloading, ICU give a lot of IV fluids. Preparation of long-term sedation and position. Patient should have fentanyl, midazolam or ketamine. Pre-oxygen for 3 minutes with NIV in case of acute respiratory. Any patient, suppose there is hypoxia, you put a NRV or you put a bag mask ventilation, at least pre-oxygenate. Why it's important? If patient comes to you, suppose saturation is 75, 78. Immediately don't take the tube. You put a bag mask ventilation, oxygenate at least for 3 minutes. See that at least 2 to 3 minutes the saturation is around 100, 100, 100, 100. Then only you attempt. Because at the 76, suppose you keep on attempting and it again goes down, there is a tough time. So when you ventilate around 100% for 3 minutes, you have some reserve. So even if you can't intubate, at least you will not cause catastrophe. So pre-oxygen is most important if the time allows you. So bag mask ventilation at least for 2 to 3 minutes, see that the saturation is around 100. But pre-oxygen is most important. Pre-medication, just now we discussed, any sedation. Now basically, during the rapid sequence intubation, patient has a head injury or there is a catastrophe, patient is in near cardiac arrest or respiratory arrest, you need to put tube in. So these are the things which you should have: ketamine, succinylcholine, rocuronium, any paralyzing agent. The dose you can read in the books actually. Post intubation, there are few ways. How do you confirm that the tube is in the trachea?
PCO.
1 second.
5-point hospitalization.
Yeah, please remember, there are a lot of ways to confirm that the tube is in the trachea. One is direct. The moment you see the tube has gone to trachea, that is visual confirmation. Other confirmation, lot of the things, but the most important just now, Dr. Gunadhar said, is capnography. The moment you put the tube in, attach a capnography. You can see the end-tidal CO2. When the patient exhales, at the end of exhalation, you see the CO2. So how do that CO2 on the monitor you can see? It should be more than 20, 25. If ETCO2 is more than, ETCO2 is normal, then you are pretty sure that the tube is in. That is the only thing which will 100% confirm that the endotracheal tube is in the trachea. Other than that, the 5-point vascular it might go sometime wrong. X-ray sometimes can go wrong. Tidal volume, patient has other lung issue, it might go down. But a few ways other than USG, direct visualization, the easiest way to confirm that the tube is in the trachea is the anti-ulcer. It's clear. Initiate long-term sedation and initial protective ventilation basically. First 2 or 3 minutes you just give 100% FIR to see that the tidal volume does not go above 6 to 8 ml per kg per body weight and pressure does not go above 30 centimeter of volume. Every 8 hourly or 12 hours you just maintain, see that the cuff pressure is on 25, don't go on increasing. Every 8 hourly or 12 hourly, at least as per your recommendation, just check the cuff pressure. Because the cuff pressure is high, what will happen? What will happen? You give 30, 40.
It will obstruct the
Offset. How will anyway, it will not offset the
necrosis of
air. Basically, it will cause tracheal injuries. So see that pressure does not go above 25. This is the last slide. Universal management for the airway management. Needs intubation. Patient is unresponsive. Crash airway algorithm. Near death, difficult intubation. You should be ready for this two operators. You can go for the rapid CPS intubation. If not, then more than 3 attempts. I'll come to that point. This is basically, these are the visualize airway, what we can see and put the tube. Now you can't do anything. You attempted more than 3 minutes. Middle of the night, nobody is coming. 10 minutes are over, 3 attempts are over. So what you do? There is one entity which is, what is this? LMA. This is laryngeal mask airway. The name itself says laryngeal mask. The larynx, it is a mask to the larynx. You don't require skill for that. Just hold like a pen and put in the mouth. Adult, you will require 4 numbers. So what you do, you put in the mouth, attach the endotracheal tube here, apna, bag mask here, bag here, and you ventilate. So whatever the air comes from that, it will go to the trachea and esophagus. LMA should be there in all ICUs. There is no excuse. You can't intubate the patient. At least put a LMA. This is blind airway, what we call, because we don't do it under visualization. Just put inside. The moment you inflate, it will just come up. So this will along the posterior pharyngeal wall, and this will mask your larynx. You put it, inflate, and ventilate till some expert comes. You don't require skill for this. Only thing you need to understand that difficult intubation. Tube has to go inside, but you can't put it. Take this LMA, put in the mouth, inflate it, do the ventilation till some expert comes. In spite of that, you can't move. There is another entity which is called as combi tube. The name itself suggests combi. Combi means combination. Combination of 2 tubes. One tube is for trachea, one tube is for esophagus. So this is the tube you put inside and inflate the 2 balloons. So there are 2 possibilities. The moment you put a tube in the mouth, there are 2 possibilities only. Either it will go into the trachea or so most of the time it will go into the esophagus. So don't worry. The name itself says combi tube. So there are 2 ports. You don't know where it is gone. Whether it is a trachea or whether it is a esophagus. So there are 2 ports. One is for esophagus, one is for trachea. So you are fortunate enough and it is gone to a trachea, well and good. Otherwise, when you inflate the esophageal balloon, when you inflate with the esophageal port, there are 2 balloons. The tube is here. The air will go from here. So this inflated balloon will obstruct the airway. The air will not go down in the esophagus. This will not go into the, it will not come up. So air will go to the trachea. It's clear? And suppose this goes into trachea only, then you inflate with this, the air will go here. Second possibility, it goes into esophagus, which is most common. So what you do, you inflated both these. So whatever the air comes here, it will not go to the esophagus because this balloon is inflated. Not come up because this balloon is inflated, air will go to the trachea. It's clear? This combi tube basically, you put inside, if it will go to the trachea, it will work as an endotracheal tube. If it goes into the esophagus, it will work like laryngeal mask airway because it is not in the trachea but it is in the esophagus, but it is not allowing the air to go into the esophagus. There are certain holes here. So in between these 2 balloons, whatever the air you are pushing, it will go to the trachea. It's clear. So in the ICU, other than the laryngoscope, this at least one thing you should have, that is LMA. And if affordable, LMA will cost around only 4,000. 700.
It can now available 2000.
2,000.
Now it is available at the cost of 150 rupees also.
Depends upon the hospital. All the ICUs along with the endotracheal tube, and if possible, combi tube. I think that's all. Any questions? Other than that, if, in spite of that, you can't do anything. The option is percutaneous thyroidotomy, cricothyroidomy, and tracheostomy, or percutaneous tracheostomy. Emergency is cricothyroidomy, but other than that, if the time permits, you do surgical tracheostomy.
Here on my talk, I am going to focus on assessment of airway. Basically, how do we assess the airway? And later on, subsequently, I will talk about how do we manage it systematically. Okay, systematic management of airway is all that very important. Okay, most of the times, whenever the patient comes in our casualty, we are all in a panicky situation. Everybody is afraid, "Hey, how to intubate? What will happen if we can't intubate?" Okay, everybody is anxious. Everybody is trying to run here and there and trying to plan out the things. But if you have a systematic planning or protocol set in before, I think this situation will never arise. Last slide of Dr. Challani, which mentions surgical airways, cricothyroidotomy, tracheostomy, all that. That stage should not come. If you assess the airway properly, that situation will never ever come. So why does the failure happen? Let me highlight on first slide that why failure happens. Failure happens because there is no discussion amongst our own colleagues. Okay, maybe amongst our staff only. Okay, maybe amongst our junior doctors, senior doctors. There is no critical discussion. There is no planning. So that's why there is no assessment also. And then there is no request for any experienced help. Most of the times we are in a very egoistic situation that no, I am very capable enough to intubate. Why should I ask for somebody? Okay, why should I ask? I am capable enough, I will intubate. That should not happen. Okay, then we have exaggerated idea of personal ability. Yes, I'll do it. There is nobody else in the hospital who is better than me. Okay, and we don't have any planning. Plan A, Plan B. Okay, in your further subsequent discussions, I guess these planning will be discussed. How do you plan out the intubation? So, not taking much of time. Whenever there is any failed airway, just relax. But don't relax too long. Relax for a few seconds, maybe 10 seconds, 20 seconds. You know it that failed airway has happened, but you have to, cool your mind, give a thought process, and ask two questions to yourself. Okay? Which technique can you use, and which technique you should avoid? Whether you should ventilate or whether you should intubate. These two questions you should have in your mind. And the second question is very appropriate. Ventilation is more important than intubation. Okay, because it is this hypoxia which is going to kill your patient. No matter if you are not able to intubate your patient, at least you should be able to do ambu bag and mask and try to ventilate the patient. That's all what is very much required when you manage the airway. And first and foremost, we should know when to intubate and when not to intubate and why we should intubate our patient. Everybody coming to the ICU gasping, low saturation and all, do you take them for intubation? No. Most of the patients, they don't require intubation as well. It's your panicky situation, your anxiety probably leads you to, take the decision of intubation. So basically the intubation should be restricted to certain situations only when there is respiratory or cardiac arrest. Patient is unconscious with GCS, Glasgow Coma Score of less than 8. I hope you all are aware, Glasgow Coma Score, head injury patient with Glasgow Coma Score who is not able to protect the airway, you intubate the patient. Any patient who is at very high risk of aspiration, okay, obese patient, perforated abdomen, okay, who is going to go for exploration, or who is very often dead, encephalopathy, he is getting feeds also, and he is at risk of aspiration, those patients only require intubation. Any patients with a burn, orofacial, maxillary injury who are likely to develop oropharyngeal edema, especially with the burns and anaphylaxis, these are the patients whom you prophylactically or electively intubate. Okay, and any patient with life-threatening conditions like pneumothorax, hemothorax, cardiac tamponade with respiratory difficulty, those are the ones who need intubation. And then at the same time, we should be aware of the complications related to the intubation. Okay, but the complications related to the intubation could be related to your equipment, related to your expertise, related to not many things. Okay, so equipment malfunction is commonest cause. Okay, when you intubate, you may damage teeth if you are not planned intubation adequately. Hypoxia, if you can't intubate, can't ventilate, the hypoxia can kill the patient. You may have esophageal intubation, that is also a complication. Endobronchial intubation, we can successfully put the tube, but is it appropriately placed? That is also very important. If the tube is in right bronchus, there will be collapse on the left side, again the hypoxia will worsen. And tension pneumothorax. If you when you have intubated the patient and you try to give larger tidal volume, aggressively you are inflating the umbu bag, then you can cause pneumothorax. So these are the complications that we can have during intubation. This was not included, I was not supposed to talk, but I felt it important before assessing the airway why we need intubation. That's why I have highlighted in my slide about need for intubation and the complications. So assessment of the airway. So can I know from your side what all are the situations where you find a difficult intubation situation? Huh? Any growth? Short neck. Anything else? Short neck, any growth in the oral cavity? Restricted mouth opening, very good. I hope there are many anesthesiologists who are coming up with the answers. Okay. So, assessment of the airway largely depends upon layman. We can quickly evaluate from this Lemon law. What is Lemon? Lemon is Lemon. When the patient comes to you, assess his airway, look him externally. From his appearance also, it can give you a very good clue as to whether this patient is going to be a difficult one for intubation or not. Okay, and then we have to evaluate by 332 rule. I will subsequently tell you how do we evaluate by 332 rule. American Society of Anesthesiologists have recommended a Malampati scoring for assessment of the airway. Basically, Malampati score gives you the internal assessment of the oral cavity, oropharyngeal cavity. There are certain structures in the oral cavity like tonsils, the pillars, the uvula, the position of the uvula, which can also give you a rough guide for the assessment of the airway. And then any obstruction in the foreign body, okay, or any tumor or a large tongue, that can also lead to obstruction. And at the same time, we have to see the neck mobility. Okay. So we have to remember while assessing the patient, Lemon. L is look externally, see from your external appearance whether the patient has difficult intubation. Second is evaluate by 332 rule. 332 rule. Second is Malampati scoring. Third is obstruction, any obstruction in the airway or neck mobility. So from external appearance, as rightly said by Dr. Short neck, short muscular neck. Okay, when the neck is short, you can't, you have a difficulty in placing your laryngoscope also inside. Okay, with a short neck, there is a lot of pad of fat in the neck and the base of the face also, which also obstructs your ventilation because the fat obstructs the pharynx and the laryngeal opening. Okay, these are the patients who can have difficult ventilation. Obesity, morbidly obese patients, sumo wrestlers. Okay, they are the one from external appearance only you can say that this patient is going to be a difficult intubation patient. Any patient with the small mandible or receding mandible, okay, they are going to have a difficult airway. Patient with the buck teeth, prominent upper incisors, From external appearance only you can tell that this patient is going to have a difficult airway. Edentulous patient, elderly patients who have lost teeth, okay, over a period of time, these edentulous patient having denture, okay, so consider them as having difficult airway. So the other possibility is patients having burn with neck contractures, orofacial burn, okay, patient with large tongue, especially with diabetics and hypothyroids, okay, they have large tongue. The large tongue also hinders your placement of the laryngoscope. And patient with the stridor, when the patient has stridor, silent chest, okay, these are the patient. From your external appearance you can consider that these patients are going to have a difficult intubation. And then fracture mandible, fracture zygomatic bone, orofacial and maxillary fractures are the ones who are going to be difficult in ventilation and going to have a difficult ventilation and difficult intubation. Now second scoring system, as I have told you, American Society of Anesthesiologists have suggested a quick and easy method to evaluate the airway quickly. Okay, it is 3-3-2 rule. 3-3-2 rules means make 3 fingers. If 3 fingers fit inside the oral cavity, the interincisor distance, like this, if you can accommodate 3 fingers inside the oral cavity, it means the patient has a normal airway. You may not have a difficult intubation or difficult ventilation. Okay, if the interincisor distance, okay, the oral cavity distance is less than 2 fingers, these patients are going to have difficult intubation. Now again calculate 3 fingers from the mentum to the hyoid. This mentum to hyoid bone is here. So you measure the mentum to hyoid bone distance. Okay, if this distance is also less than 3 fingers, then it is difficult. Okay, and then 2 fingers calculate from the floor of the mouth to the thyroid cartilage. This is the thyroid cartilage, and from the floor of the mouth to the thyroid cartilage, if it is less than 2 fingers, then the scoring is high and patient will have difficult intubation. So what is 3-3-2 rule? 3 fingers inside interincisor gap, 3 finger distance from the mentum to the hyoid bone, and 2 fingers from floor of the mouth to the thyroid cartilage. Okay, this assessment will tell you about intubation. Next is Malampatti scoring, as I have already told you. Malampatti scoring tells you about the structures inside. It is divided into 4 classes. Basically, when you assess Malampatti score, you make the patient seated on chair. You also seat exactly opposite to him, having eye-to-eye contact, exactly parallel with his eye contact. Okay, and ask him to open his mouth. Okay, on opening of the mouth, if you can see 4 structures inside. What are those 4 structures? One is uvula, second is tonsils, third is before tonsil there is anterior pillar, and behind the tonsil there is posterior pillar. Okay, if you see these 4 structures, okay, it means the Malampatti class is class 1. Okay, if you can see all these 4 structures, uvula, okay, tonsils, okay, anterior and posterior pillar, it is class 1. Class 1 means it is easy intubation. You should be relaxed. Okay, second class is when only soft palate. Sorry, I forgot to tell you about the soft palate. So tonsils, anterior and posterior pillars, okay, uvula and soft palate. These are the 4 structures. Soft palate is behind the hard palate. If all 4 structures are seen, it is class 1. If only the soft palate, tonsils and the uvula is seen, it is class 2. You may have little difficulty in intubation. Third is soft palate and base of uvula. If you are able to see only the base of the uvula and the soft palate, then it is MPC, Malampatti class 3. You are going to face a difficulty in intubation. And fourth is only hard palate is seen, nothing is visualized. Only the hard palate is seen. Neither the tonsil nor the anterior pillar, posterior pillar are seen, then it is MPC class 4. If you have patient with MPC class 4, he is definitely a difficult intubation case. You need proper planning, you need experienced help for such patients. Okay, next is obstruction. Okay, what are the things which can cause obstruction to the oral airway? Blood, especially with oropharyngeal injuries. Okay, any vomiters, if the patient vomit and the solid particle they accumulate, that can cause obstruction. Teeth while intubation, or if there is a loose tooth and the loose tooth gets dislodged, it can go into the larynx and it can cause obstruction. Epiglottitis, especially with the kids, viral infection, their epiglottis becomes infected, large, and it obstructs the airway. Patients with the denture, I have told you to. Any patient with the tumor inside, the oral tumors like CA tongue, CA cheek, okay, these patients are likely to have obstruction. Okay, and any patient with the impacted object can have obstruction, and you will have difficulty in assessing the airway. Okay, next is neck mobility. Check his neck mobility. Ask him to flex his neck. Okay, and you can actually measure the angle from the interincisor to to the base of the floor of the mouth. Right, like this. In this, you can see the angle. Okay, if this angle is acute, okay, then patient has a difficult intubation. So I have just told you thyromental distance. What is the thyromental distance? 2 fingers, floor of the mouth to the thyroid cartilage. If it is less than 2 finger or less than 7 centimeter, these patients are likely to have difficult intubation. Okay, so we all understood how to assess the airway. The assessment of the airway is by layman. Look externally. Okay, next is any obstruction, Malam Patti scoring. Okay, evaluate patient. Okay, and then neck mobility. These 5 parameters you have to see when you are assessing the airway. So now how to manage these patients? If you have even for normal intubation or difficult intubation, your mask ventilation is going to be very much important. So when will you call it as your patient as having difficult ventilation with the mask? Okay, any patient with the beard, obesity or edentulous, these are the patients who are going to be difficult to ventilate with the mask. Elderly patients, they don't have any pad of fat on their face. Okay, the mask doesn't fit properly, there is a lot of leak, so that's why they don't get ventilated properly. Any patients who are obese, who are snoring, okay, they have a lot of pad of fat in the pharynx, and when you try to ventilate, the pharyngeal fat comes in the way and causes obstruction. So these are the patients where you have difficulty in ventilation. So remember mnemonic bones. In order to find out difficulty in ventilation, beard, obesity, no tooth, elderly and snoring patient, these are the ones who are going to be difficult for ventilation. And which are those patients who are going to be difficult for intubation or laryngeal visualization? Okay, here we have to see whether there is any disproportion. Patients with Pierre-Robin syndrome, acromegaly, prognathism, okay, patients with buck tooth, okay, having achondroplasia, okay, these are the patients you can't intubate. Okay, you should have a protocol or management plan before resorting to intubation. Patients with distortion, having oromaxillary distortions, like having neurofibromatosis, patients with burn contracture, okay, these patients with cystic hygroma, these patients cannot be intubated with your usual intubation skills. You need very sophisticated and advanced techniques to intubate these patients. Patients with atlantoaxial joint or TM joint ankylosis, these are the ones where you cannot you cannot expect that patient to have a good mouth opening. Okay, patients with advanced age having ankylosing spondylitis with loss of curvature of the cervical spine, you will not be able to give sniffing position, head tilt, chin lift will not be possible. These are the patients who can have difficult intubation. Okay, patients with Klippel-Feil syndrome, you can't intubate with usual base. Okay, edentulous patients, okay, buck teeth, can't intubate. So routine causes of difficult intubation are related to the person who is intubating, maybe anesthetist or maybe yourself when you are trying to intubate. So that's why you need to check all your equipments. Okay, you need to update yourself every time. Even though you may be expert in intubation, but you have to update, like attending these conferences or CMEs. It will help you to update yourself. And whenever the help is required, don't hesitate to ask for any help. Ask for experienced help. Okay. So rapid sequence intubation is the one which is going to help you in these difficult situations. What is the rapid? When you have a difficult intubation scenario, okay, or usual intubation, you should have a rapid sequence intubation where you induce the unconsciousness in the patient with complete neuromuscular paralysis. So basically what happens with inadequate sedation, inadequate analgesia, we try to intubate the patient struggles. Okay, when the patient struggles, you also struggle putting the laryngoscope inside, and in the process what happens, there is injury to the tooth or injury to the tongue, injury to the oral cavity, and then this patient they bleed. So if you paralyze them with adequate doses of paralyzing agent, when you are confirmed that this patient doesn't have difficult intubation, okay, you use rapid sequence intubation, use enough of paralyzing agent, and then you intubate these patients. So intubation bundle is a protocolized approach. Bundle is something which is called as a checklist before intubation. You do a checklist before you go for intubation. This checklist is called as intubation bundle. So there are 7 P's. If you can remember these 7 P's in your intubation bundle, probably we will be able to avoid the complications related to ventilation and intubation. So what are all these 7 P's? First is preparation. So for preparation of intubation, okay, you should spend some time, okay, but not too much. So the preparation should take maximum 10 minutes if the intubation is elective. But as Dr. Challani has said, in ICU you may not have any time, you may not have these 10 minutes to prepare. So that's why you should have your trolley ready. Trolley containing tube, laryngoscope of different sizes, endotracheal tubes of different sizes. Then your airway accessories like oropharyngeal airway, nasopharyngeal airway should be available in advance. Okay, so the preparation has to be optimum. Before any intubation techniques, the preparation has to be optimum. Okay, then when we intubate the patient, the commonest cause of failure in intubation is improper positioning. Okay, patient is lying down on a stretcher or bed or an OT trolley, and we don't give enough or adequate position, we fail. Why we fail? Because generally the visualization of the larynx depends upon bringing the oral, pharyngeal and laryngeal axis in the same plane. Then only we will be able to visualize the larynx. Okay, generally the oral cavity has a plane this direction. Okay, then the pharyngeal axis has the plane in this angle. So there is an angle, acute angle, and then the larynx is again having the other angle. So these oropharyngo-laryngeal axis are not in the same plane. In order to bring them in the same plane and visualize the larynx properly, okay, we give them a good position. Okay, so positioning is very, very important when we intubate this. Sniffing position is head tilt, chin lift, and jaw thrust. You ask the patient to extend the head. Okay, then what do you do? Head tilt, you ask him to tilt the head. First you get a neck extension, neck is extended, ask him to tilt the head, and then you lift the jaw. You lift the jaw at this angle of the mouth. You try to lift the jaw and bring it anteriorly or at the level of the upper incisors. Okay, so this sniffing positioning is going to help our successful intubation. So the positioning is very important. Pre-oxygenation. Pre-oxygenation is very important in the sense that while intubation, sometimes we take a lot of time, maybe 3 minutes, 4 minutes, and in the process the lungs lose their oxygen reserve. Okay, in order to maintain the good oxygen reserve in the lung, we need to pre-oxygenate the patient for at least 5 minutes with 100% oxygen, so that the oxygen reserves are well maintained, and even during your longer durations of attempts of intubation, patient will not become hypoxic and he will not desaturate and he will not have respiratory arrest. So that's why the pre-oxygenation is very, very important. Pre-oxygenate the patient for at least 5 minutes. It's not that pre-oxygenate kar diya, 2 minutes ho gaya, khatam ho gaya, chalo intubate. No. If it is elective intubation, give some time, okay, to improve the oxygen status. Next is pre-medication. Okay, pre-medication, what all drugs we do use pre-medication? Sorry. Pre-medication, what all drugs do we use for pre-medication? We all must have, huh? Propofol, directly we will use propofol. Midas? Anything else? Huh? Fentanyl, anything else? Directly atracurium. So your medicines should include, pre-medication should include sedative agent and analgesic and one paralyzing agent. 3 drugs are involved. Okay, and when you give these drugs, these patients do develop sometimes increased secretion, sometimes they develop bradycardia due to increased vagal tone, because when you try to intubate, the vagus is stimulated due to pharyngeal stimulation and they do develop bradycardia. So that's why you should have these 3 drugs: sedative agent, either benzodiazepine, midazolam, diazepam, analgesic agent like fentanyl, okay, morphine, okay, tramadol, and then you should have some induction agent like propofol or pentothal sodium if you are doing elective intubation. But in ICU, probably these patients are already hypotensive. If you use propofol or thiopenton, they may have sudden drop of blood pressure. So that's why these pre-medication agents may be avoided. You use midazolam, fentanyl, okay, and then use straight away paralyzing agent. Which is the paralyzing agent that we use? Succinylcholine. Okay, if the patient doesn't have hyperkalemia or any burn history, you can safely use succinylcholine. But if there is contraindication, then you should use either atracurium or rocuronium or any other agent like vecuronium or pancuronium. Okay, so use your agents judiciously. Okay, next is, once you put the tube, okay, you have to confirm the placement of the endotracheal tube. Okay, take 45 seconds and confirm the placement of the endotracheal tube. How do you confirm the placement of the endotracheal tube? How do we confirm? Capnometer is the gold standard. Any other method if you don't have capnometer? 5-point auscultation. Okay, auscultate on 5 points: right upper zone, left upper zone, left lower zone, right lower zone, and at the end you should auscultate epigastric region also. Okay, sometimes you may not be able to detect the esophageal intubations on your usual 4-point auscultation. So the best way to diagnose esophageal intubation is to auscultate on epigastric region. But capnometer is mandatory for all intubation status. Capnometer should be available. And then post management, post intubation care is very, very important. Post intubation, what do? We keep them sedated, do X-ray chest, okay, find out the proper position of the endotracheal tube. Okay, the endotracheal tube, the tip of the endotracheal tube should be above the carina, 2.5 to 3 centimeters above the carina. Okay, so in these 7 P's, what we have learned, the preparation should be done within 10 minutes for elective intubation. You should achieve good positioning. You should pre-oxygenate the patient for at least 5 minutes, not more than 5 minutes. You should give good pre-medications, sedatives, analgesics, okay, and then paralyzing agent. Paralyze properly. Confirm the placement of the endotracheal tube by 5-point auscultation, capnometer, and do X-ray and check the position of the endotracheal tube. And post procedure, post intubation, what we should do? We should keep them sedated, either keep them on ventilator, okay, give maintenance, sedation and analgesia, okay, and then, so as I have told you, preparation can be done very quickly, okay. I will just summarize. Preparation can be done quickly by simple layman scoring, okay. Look externally, evaluate by 332 rule, do Malam Patti scoring, see for any obstruction, see for neck mobility, okay. Check your laryngoscope all the time, okay. Most of the time when you are trying to intubate, either the bulb is not functioning or the battery is not working or the battery is exhausted. So before intubation, check laryngoscopes and get acquainted with your laryngoscope. You should know how to use it before intubation, okay. There are two types of laryngoscope blades. One is straight blade laryngoscope. This is the straight blade, which is called as Miller's blade, and the curved blade is called as Macintosh blade. This one is the okay. This is the Macintosh laryngoscope, where you can see the curvature of the blade is maintained, whereas these are the straight blades. Basically, the straight blades are used for patients in a pediatric population where their epiglottis is large, okay. So when we intubate the patient with straight blade, you have to include the epiglottis, and when you use a curved blade for intubation, you don't include the epiglottis, you go into the aryepiglottic fold. So basically you need to know which blade when to use. Straight blade for pediatric patient, curved blade for adult patients, okay. Then along with the intubation, we should check the endotracheal tube properly, okay. The cuff is working properly or not, okay. And do you have a stillate? Sometimes the negotiation of the endotracheal tube through the larynx may be difficult. So in order to facilitate your easy placement of the endotracheal tube, we should use stillate at times. So prepare your equipment, check the cuff properly. Appropriate size of the endotracheal tube is very, very important. Okay, if you use larger endotracheal tube, it may cause necrosis or injury to the trachea. So that's why usually number 7 endotracheal tube is recommended for female patients, and number 8 endotracheal tube is recommended for adult male patients, okay. So check your instruments before intubation. What all these instruments are required for intubation? Bag, mask, valve. Appropriate size of the ambu bag and mask is also very important. If you are using a pediatric ambu bag and mask for adult patient, that's of no use, okay. Keep the ambu bag and mask beside the patient all the time, so that in any emergency you can use it quickly and you can save your patient, okay. So you should have these tincture iodine and stickers also ready. You have intubated the patient, but then you keep waiting for application of the stickings. So that's why the sticking should be ready all the time, okay. Then Magil forceps. Sometimes the endotracheal tube is difficult to be negotiated. This Magil forceps will help to further place the endotracheal tube. Lignocaine can also be used for patients when you want to avoid excessive intubation response. When you intubate, it is very painful and it can cause tachycardia, and especially patients with ischemic heart disease may be vulnerable to this response of tachycardia. So to blunt this tachycardia response, you can use lignocaine, okay. And then you should have water soluble lubricant, use gloves, okay. Use all your aseptic precautions to prevent infections after intubation. Give good sniffing position. This is how you should give a good sniffing position in order to bring oropharyngolaryngeal access in the same plane, okay. You can see when you give proper position, this oropharyngolaryngeal axis are in same plane. Otherwise what happens, the oral axis is this direction, okay, the laryngeal axis is in this direction, and then the pharyngeal axis is in this direction. So that's why you can't see anything if you don't give good position. So that's why if you give a good sniffing position, head tilt, chin lift, jaw thrust, okay, all the oropharyngeal laryngeal axis will come in the same plane and you can visualize the larynx smoothly and properly. Preload the patients. Okay, because when you use excessive sedative agents like benzodiazepines and fentanyl or propofol, they invariably the blood pressure drops. Okay, there are certain patients who are susceptible to drop in blood pressure, especially ischemic heart disease patients. Okay, so you preload these patients with 500 ml of crystalloid. Any fluid you can use, but crystalloids are preferred. Okay. Pre-oxygenation of the patient is just not to increase the oxygen reserve in the lungs, but to cause denitrogenation. What happens? Generally in the air there is 78% of the nitrogen and 21% of the oxygen. Okay, if you remove this nitrogen and you build up everything, you enrich alveoli with lot of oxygen, the oxygen reserve will improve and they will tolerate hypoxia for a long time. Pre-medication, as I have told you, very important to blunt the physiological response, avoid bradycardia and hypoxemia. Pre-medication will also help you to blunt cough and the gag reflex. Patients with the head injury may be very susceptible to the increased cough reflex because it can cause increased intracranial pressure, okay, and it can cause secondary brain damage. So be very cautious. The pre-medication will help you to reduce cough and gag reflex. Pre-medication drugs include lignocaine, opioids, atropine for bradycardia. Lignocaine I have already told you, it will blunt the sympathetic response. Okay. Atropine for bradycardia. Paralyzing agents like succinylcholine or vecuronium or rocuronium can be used. Succinylcholine is very short acting muscle relaxant. It is a depolarizing muscle relaxant. Vecuronium and pancuronium and rocuronium are long acting agents. So choose your drug. Succinylcholine can be avoided in patients with a burn or patients having hyperkalemia or muscle injury because succinylcholine causes release of the potassiums and muscle necrosis because it causes a lot of twitching. So avoid succinylcholine in this patient, otherwise it's a fantastic drug, okay, because the onset of action is very fast within 30 seconds and the action lasts for 90 seconds. Even if you have difficult intubation, okay, the action will go off within 90 seconds and you will be able to bring your patient back, okay, after the paralyzing agent. So very good agent. Sedative agent should be used judiciously. Barbiturates like thiopentan sodium, okay, propofol are very useful to give good anesthesia, but the dosage should be remembered. Okay, the dose of propofol is 1 to 3 milligram per kg for IV induction. Okay, if you use propofol, suddenly 10 ml, 20 ml, if you give, there will be a precipitous fall of blood pressure. So that's why the propofol has to be given slowly. Ketamine is also very good anesthetic agent to induce a good intubating condition and give good anesthesia, and it gives good analgesia also. Okay, it's a good bronchodilator, especially it can be very useful in patients with asthma or COPD. Fentanyl in appropriate doses gives good sedation and good analgesia both, but the appropriate dosing is 2 to 10 micrograms per kg IV. Morphine can also be used for analgesia and sedation. Okay, but the dose is 0.1 to 0.2 milligram per kg, but patients with asthma may be susceptible because it causes histamine release and cause bronchospasm. It causes sedation for a long time. The half-life is 4 to 6 hours. So if the procedure is very short, you can avoid, you can use fentanyl. Benzodiazepine like midazolam, diazepam, lorazepam can be used. So before intubation, we can give Salix manual because some of the patients who directly come to our hospital, you are not sure whether they have taken their last meal recently or not. And these are the patients, if you try to attempt intubation, they are likely to aspirate. And then you have to keep treating their aspiration pneumonia. So to prevent aspiration pneumonia, you just need to use your Salix manual before intubation, give a proper pressure over the cricoid, and the cricoid will block the esophageal opening, okay, and can prevent aspiration. Do intubations under proper visualization. Don't put the tube blindly. Don't hesitate that you are not able to see the larynx and get a call for help. Okay, just you have done laryngoscopy, you are very senior and you are not able to put laryngoscopy and put the tube blindly is not good. Okay, So intubation and the placement of the tube should be done only when you have seen the larynx properly. This is how the larynx looks like in a laryngoscopy, and there the tube should be placed. Inflate the cuff of the endotracheal tube after placement, okay, because when you are not inflated the cuff, again they have high chance of aspiration, okay. How do we do intubation in cervical spine injury patients? Always give them cervical spine stabilization, okay, because your laryngoscopic attempts may cause partial fracture may get partial fracture, or displacement of the cervical spine may get converted into a complete fracture or complete dislocation of the cervical spine. So when you are intubating or ventilating these patients, you have to take a special precaution that they should have manual inline stabilization. Like here in this patient, you have seen this person has stabilized the cervical spine anteriorly, okay. So cervical spine patients, unless proved otherwise, they should have manual inline stabilization, and then you cannot give head tilt and chin lift in this patient. You can just give jaw thrust and try to visualize the larynx. All patients with the cervical spine, unless proved otherwise, are considered to have difficult intubation, because you cannot get that sniffing position in these patients. Okay, so do manual inline stabilization, apply Salix manure every time. Okay, ventilate, confirm the placement of the endotracheal tube, and once the tube is in, okay, apply cervical collar and confirm the placement of the endotracheal tube by capnometer. There are two types of capnometers. This is calorimeter, and second one usual capnometer, a monitor where you can see the waveforms. Okay, every time you may not have that monitor, so you can use this calorimeter. Probably it may be available in your code blue bags also. If the tube is in endotracheal tube, the color will change from purple, this purple color will change to yellow, okay. If the purple color changes quickly to yellow, it means the tube is in trachea, okay. But if this purple color changes to brown, the tube is in esophagus, okay. So this interpretation is very important. Having just this calorimeter, capnometer is not enough. You should know what color changes, okay, and what is the interpretation. If the color changes from purple to yellow, it is in bronchus. If the color changes to brown, the tube is in esophagus. So there are other esophageal detector devices also, okay. You just deflate the balloon and apply it on the endotracheal tube. If it gets inflated, the tube is in trachea. If it doesn't get inflated, the tube is in esophagus, okay. Then the post-intubation management. Secure the endotracheal tube, do ventilation properly, gently with low tidal volume, and apply a ventilator. Pulse oximeter saturation, you should achieve a saturation of above 94%, okay. Use your end tidal CO2 monitor. You should be able to see good waveforms like these good waveforms, okay. If you can't see these waveforms, the tube is in esophagus. And continuously recheck and reconfirm the placement of the endotracheal tube. Just don't relax, because the tube may get dislodged during your transportation, during your handling, during the change of position, okay. So continuously keep checking and reconfirming the placement of the endotracheal tube. Post intubation care includes give fluids, because sedative agents will cause hypotension. You need fluid. You should apply good monitors, all the monitors including pulse oximeter, capnometer, ECG, all these. Apply vasopressors if the patient has precipitous fall of blood pressure momentarily. You try to raise the map. Ventilator setting should be judiciously used. I mean, whatever, whether it is volume control, pressure control, you should use tidal volume appropriately. 6 to 8 ml per kg. You should have a PEEP of 5. FiO2 initially 100% and then gradually come down, try to get it below 60%. Then do one X-ray and chest, X-ray chest and check the placement. The tip of the endotracheal tube should be 2.5 centimeters above the carina. And when you are paralyzed, okay, you can use reversal agent to take him out of the paralyzing agent. You can use reversal agents like neostigmine and glycopyrrolate or atropine. What all things you should have in your difficult intubation kit, okay? So these are the instruments which you should have in your difficult intubation kit. Laryngeal mask airway. Okay, it is the important tool to have in your difficult intubation. Okay, if you can't intubate, at least put a laryngeal mask airway. You will be shown laryngeal mask airways in your workshops. Okay, there are different types of laryngeal masks which are available. You can actually intubate the patient through the LMA. This is called as intubating LMA. If it is possible, keep intubating LMA in your difficult intubation kit. You should have a bougie. Okay, sometimes you are able to see the vocal cords, you are able to see the larynx, but you are not able to put the tube. Okay, because the tube diameter is big, can't pass the tube properly. So put a bougie through the vocal cords and pass the endotracheal tube through the bougie like a railroad technique. Okay, once the tube is in, remove the bougie. So bougie will also help you in your difficult intubation kit. Fiber optic bronchoscope, generally for elective intubation, should not be used in emergency situations. Okay, if patient has all these problems like disproportion, disfigurement of the airway, difficult airway, we should have fiber optic bronchoscope also available. Video laryngoscope has made the life very easy nowadays. Okay, we have a laryngoscope with a video monitoring on a monitor, and you can do intubation. Cricothyroidotomy set. If you can't intubate and can't ventilate also, should have cricothyroidotomy set, which is the most life-saving instrument. Okay, just give a nick on the cricothyroid membrane, put the cricothyroidotomy set, and you ventilate the patient. You can buy time. Definitely after cricothyroidotomy set, you have to switch over to a definitive airway by putting a tracheostomy or by doing a proper intubation. Jet ventilation. Sometimes all these tools are also not available. If you have jet ventilator, okay, this is like forcefully giving oxygen through a cricothyroidotomy. And then ultrasound can also help you in assessment of the airway, and or proper placement of the tube also can be confirmed by ultrasound. If you are not able to visualize the larynx also indirectly, ultrasound will help you in your.
And plus you listeners to bring to this platform 3C. As it was told here, 3C is totally a non-profitable organization. The aim of that is to bring down the mortality rate in the ICU. How it can be done? It can be done only when people like the specialists or the faculties teach the staff nurses, were very important. Not only the staff nurses, the paramedics also. Not only the paramedics, each and every staff of the hospital should know there's a critical care situation. So it's wonderful to be motivated from all of you so that we can continue this work. And thanks once again to Wockhardt for this product. This is the first corporate setup where we have put up this kind of training actually. We hope as upcoming staff nurses, paramedics, anesthetists, doctors will save a lot of lives actually. And we Indians are not less compared to any other Western country, medics or staffs or this thing. So all the best to you, and thank you sir, thank you so much.
Thank you.